there is just one lady that I was supposed to scan, and she has very young pregnancy, so CRL of the baby is 45 millimeters. And for this CRL, I'm not scanning transabdominal, I'm doing transvaginal scan because transabdominal resolution for CRL up to 55 millimeters is not enough. For every baby that have CRL of 55 millimeters or less, I'm doing transvaginal scan, and mother understandably doesn't want to have scan in front of everybody. So unfortunately, there is no demo. I'm sorry. So probably you would like me to talk, or you will continue?
I want to speak about the mediastinal arterial arches. It's not a new, it's before the 3V trachea view. It was first published in 1993. And for you, it's a new practical approach to diagnose cardiac anomalies in the early, and I think also in the late stages of pregnancy. According to the guidelines of ISWOG, Fred spoke about what consists of fetal echocardiogram, and they spoke only to high-risk patients, which is a complete mistake. I hope you agree with me. And 3 vessels view, and trachea still views of the great arteries. And my question to the committee, have you forgotten the transvaginal sonography? And I asked Yagel, who was in this committee, why was quiet? Why didn't you suggest to do also the vaginal exam where it's possible? So he told me there were 10 people against me. I told them that they completely refused this approach. And actually, we can depict all the cardiac organs in the early stages. And we believe that the advantages of the TVS are obvious when fetal organs are scanned in early pregnancy. The fetal heart may be examined in details, including chambers, artery, as early as 10-13 weeks. Cusp and vein as early as 14-16 weeks. I want to speak about 81,000 examinations between weeks 14 and 16. Good. No? Okay. In children and adults, the cardiologists traditionally use the standard classical views of the heart. Because Fred showed it, but I want to say again, because there's 4 holes through which they are looking. So they have to speak about views. In fetus, the ribs, especially in the early pregnancy, are only slightly ossified, and there is no air in the lungs. Therefore, in addition to the classical views, depiction of the heart from various directions, angles, including the posterior directions through the back, is possible. And I can do a complete exam through the back, and yesterday you saw me looking at the apical directions through the back, and I saw which ventricle is what. So many of my examinations are through the back. It's possible to do in vaginal through the back. And we would like to share with you a new approach which does not rely on still picture of the classical views, but rather on continuous video motions, because we are looking like with video, so we have to see the structure, not the views. And there are 3 groups of images: the 4 chambers, it's apical, and also from the lateral, the outlet views or the arches views, and I call these views the structure, the incomplete figure 8, and the venous views, which maybe another time I'll give you a lecture. So So we are looking at this structure. So it's incomplete figure 8. And what is the incomplete figure 8 which we are looking with video? Am I speaking about this structure? Look at the structure. Don't look at cuts of the structure. Because I can publish another article about 6 additional views. Please look at the structure. At this incomplete figure 8 tube. This is incomplete. This is I would call the X region, the inverted P region, and the Y or the V region of this structure, which I call it incomplete figure 8. And actually, we published in our book before the 3V tracheal view, the incomplete figure 8. The X, the Y, and the inverted P. Another. So we should study to see this view, and around the aorta there is a superior vena cava trachea, and we can see the right pulmonary artery and the left pulmonary artery. And every doctor who is coming to study with me has to buy a plasticine. And when I'm doing the exam, I'm showing in which direction I'm. So it's very easy to study it. For example, I'm showing this in the early stage. I'm asking him, he should show me this structure. I'm showing this, and he have to show me this structure. And incomplete figure 8 can be diagnosed very easily week 10, and even week 9. You see the V sign. Such. The width, as Fred said, of the vessel should be identical. And if there is a discrepancy between the vessels, and if it's a severe discrepancy, it's severe anomaly. You have to look only at the vessels. If there's a severe discrepancy, it's a severe anomaly. And my method is a little different than Fred. I'm saying that the heart is like a pump which pumps through parallel vessels. And the vessels are with low compliance, elastic, and when there is an obstruction of one of the vessels, there must be a compensatory dilatation of the other. In the chest, it's the pump through 2 parallel vessels. So, it's simple common sense. Okay, and I'll give you a simple way to look at this incomplete figure 8. One, the possibility one is the left outlet. This is the aorta, is smaller than the right outlet. You look at the vessels, you see the left vessel is smaller, the right vessel is wide. Like in this case, this is smaller aortic arch, wide right outlet. And this is most probably it's coarctation, and this is hypoplastic left heart syndrome. This is left, and this is right. When the discrepancy is severe, it is most probably hypoplastic left heart syndrome. And acyclic ventricle is a normal outlet. In my experience, some of such cases, it was transient and the babies were normal. So take messes, for example. You cannot diagnose hypoplastic left heart with normal aortic diameter. You cannot diagnose. So the diagnosis of left hypoplastic left heart syndrome should be through the vessels. For example, we had 68 cases in the early stages of hypoplastic left heart syndrome. I'm waiting. It's still not diagnosis. Another case, okay, with the color there is no feeling, but the final diagnosis look at the arches in the vagina, and you can see smaller reverse flow of the aortic arch, and I don't know out of these 88 cases in which there was hypoplastic left heart syndrome with normal direction of the aorta and normal size of the aorta. So this is my diagnosis of hypoplastic left heart syndrome. About coarctation. Smaller aortic arch, wide right outlet. Smaller right outlet, wide right outlet. And if we are using the 3 vessels view, and this case of tubular coarctation, we can miss it. So we should look at the structure, not at the views. And I understand your doctor which says we cannot diagnose coarctation in utero. We should speak about the probability of coarctation. We never say it's coarctation. You can say higher probability to coarctation. So it's not detectable in utero coarctation. Because after closure of the ductus, the aorta may expand. Or after closure of the ductus, the aorta may remain narrow. The closure of the ductus only after the delivery. Some of the examples. Here we can see large right outlet, week 16, very narrow aorta. This is the cervical vessels which are, I thought it's coarctation. Week 17. See, this is the left outlet, this is the right outlet, this is left pulmonic artery. I thought it's coarctation. But after the delivery, the ductus closed, the aorta expanded, it was normal outcome. Another case, mild. You can see mild discrepancy. This is the aorta, this is the right outlet. Aorta remains narrow and there is a coarctation. Another case, right outlet, left outlet, week 18. And the aorta remained narrow, it was a coarctation. In many cases of coarctation, it was also smaller left ventricle and smaller aorta. And this phenomenon we called right dominance. And if it's right dominance, it is a higher probability to coarctation. Not sure, but higher. And the publication in the prenatal diagnosis in 2007, if there is a right dominance in the second trimester, only 60% of this right dominance is coarctation after birth. If the right dominance appears only in the third trimester and it was normal in the second trimester, the probability of coarctation only 14%, 86% of them are normal. And often this discrepancy associated with bicuspid aortic valve. But right dominance in early pregnancy is 70%, to my experience, about 28 cases of coarctation, about 100 right dominance, 70% is coarctation. So take home message. If the early scan is normal and right dominance develops later, it is not a coarctation. And here we can see this is the right outlet, smaller left outlet, and it was bicuspid aortic valve, which we can, with new machines, we can see here the Mercedes size appearance, week 15. And in this case, we can see straightened lines of bicuspid aortic valve, which can be diagnosed in the early stages of pregnancy. Okay, the second, no, I'm not measuring. Gestalt, my gestalt. I'm not doing diagnosis with calipers. No, I'm looking. You see, smaller left ventricle. Asymmetrical arches. So the first is smaller left arch, which might be coarctation, which might be normal, which might be hypoplastic left arch syndrome. The second, symmetrical arches, when the left arch is big, the right arch is small. Fred spoke about it. And in most cases, 99%, it's tetralogy of Fallot. So I'm giving you a clue how to diagnose tetralogy of Fallot. Look at the arches. If the right arch is small, the left arch is wide. This is 99% tetralogy of Fallot. You don't have to look inside overriding and others, which is tricky, the overriding. And it's 20% 26 years ago, first case of tetralogy. And we should remember that if the right outlet is equal to the left outlet, it is not tetralogy of Fallot. There is some disagreement between the cardiologists what is tetralogy of Fallot. But the classical tetralogy of Fallot, if the right outlet is the same like the left outlet, it's not tetralogy of Fallot. And autopsies in our pathological department, small discrepancy. I ask him, please don't open the heart. It's tetralogy of Fallot. Another case, it's a finger. Look the size of the heart. Small right outlet, huge left outlet. Tetralogy of Fallot. This is the incomplete figure 8. Again, and again, and again. So, in cases of early pulmonary atresia, there is no enlargement of pulmonary artery, right or left, because I think it's not tetralogy of Fallot. If this appears with overriding aorta, normal size, it might be pulmonary atresia without ductus, like in this case. So there is no ductus. It's pulmonary atresia. Later, one of the pulmonary arteries should be like a balloon. But in the early stage, it doesn't appear. In another case, no ductus, so it's pulmonary atresia. And some people call it tetralogy of Fallot with pulmonary atresia. I prefer it's another entity. And this is the classical appearance of inside the heart of tetralogy of Fallot, overriding, which is not specific to tetralogy of Fallot, smaller right outlet, week 15, and huge left outlet. Again, this is huge aorta. Tetralogy of Fallot, week 12. I don't have to look at the heart, and I look at it was VSD and overriding aorta, smaller right outlet, huge left outlet. Last case, smaller right outlet, huge left outlet. So, and overriding is not a specific sign for tetralogy of Fallot. Another case in which I saw almost normal width of the right outlet with normal width of the left outlet overriding. And some cardiologists call it tetralogy of Fallot, but for me it's not, because they are always the same. And it is called Eisenmenger syndrome, the autopsy. Look, it's normal pulmonary artery, normal aorta. So VSD with overriding aorta, for me it's not Fallot. Some of our cardiologists call it tetralogy of Fallot. Through discussion between doctors. Eisenmenger VSD. Okay, let's do the first. So we spoke about huge right outlet, huge left outlet, and now we speak about single vessels in the upper mediastinum. We are looking at the upper mediastinum, as Fred shows it with beautiful slides. And if we see single vessels in the upper mediastinum, you see single vessel. You cannot see figure 8. So you are going to the 4 chambers view, and you can see single ventricle. Week 14. It is her first pregnancy. Her second pregnancy, I invited her week 11, and we can see single vessels in the upper mediastinum. Again, univentricular heart, second time. And we can see the heart. The third time, week 9 and 6 days, single vessel. I cannot do, it's vagina, good probe, it's most probably single ventricle, but in PM it's single ventricle. The first time, she came to us week 9, and look, we can see here the V sign. And week 9, I told her, okay, you're at bed 3. Pregnancy, this pregnancy, I sure will be normal. So week 9, we excluded single ventricle, not by the ventricles, but the incomplete figure 8. We could see the V or the Y sign. And week 10, then we succeeded to see the 4-chamber view. And she delivered beautiful child. Another case when we see a single ventricle in the upper mediastinum. We can see, so what is your diagnosis? Fred spoke about it. We should go to the 4-chamber view, and in another case of single vessel in the upper mediastinum, normal size. It should be normal size and it can be wide. So if we can see a single normal size vessel in the upper mediastinum, and it is not single ventricle, this is the 4 chambers. So diagnosis, Fred showed it before, it should be transposition. So diagnose transposition, look at the upper mediastinum, single vessel, look at the 4 chamber, it's 4 chamber view, it's transposition. You don't be so clever to diagnose it. Because in single, the arches are one above the other, and to see if they are parallel, you should do the sagittal section. And we can see the parallel outlet of the vessel. In the upper mediastinum, we can see only above. And you can see the autopsy, and 28 years ago, we can see the parallel outlet with the ESI 1000. We can see very beautiful the cortez single. You can see the single. And the autopsy, which explains why do we see a single, one beneath the other. They are parallel. And in the PM, if you are looking above, you can see single ventricles, also week 15. But if you are looking a little bit sagittally, we can see one beneath the other. And we had 30 cases of transposition. Here is week 15, the classical view. Color is good for publication. We don't need color and many autopsies. So let's speak about parallel vessels. It's not only transposition. Here, week 10, parallel vessel. Most of them are transposition. Corrected or not corrected. Some of them are double outlet right ventricle. Some of them dextrocardia, and some of them right aortic arch with right ductal arch, which I'll speak later. So in 90% parallel outlet or single vessel, if it's not a sagittal section, it's transposition of great arteries. We're speaking of such side fetus. Double outlet right ventricle also might be, and here you can see parallel outlet, but this both outlet from the right ventricle. Another case of single vessel, and if we are going a little bit sagittal, we can see 2 huge vessels from the right ventricle with VSD and the left ventricle. Another case, week 15, I'm putting the probe, I'm looking at the upper mediastinum, no incomplete figure 8, only single vessel. So very easy, no? Single vessel is an anomaly. But this kind was congenital corrected transposition. Another case, dextrocardia, which in some cases might be parallel great vessels. So we spoke about single vessels, normal size, but it might be wide single vessels. It might be pseudo single vessel, and Fred showed it very beautiful. It may be associated with Fallot, double outlet right ventricle, or hypoplastic left heart syndrome. Because the second tiny vessel is hidden. It's very tiny. So it's the severe bad prognosis. It was Fallot, week 16. What if it's wide true single, and sometimes we cannot differentiate between them? Most of the time we cannot differentiate between them. And if it's true single, it's truncus arteriosus, week 15. And week 12, truncus arteriosus, single huge vessel in the upper mediastinum. Take-home symmetry. Very narrow left outlet or aortic arch. It's hypoplastic left heart syndrome, especially with reverse flow. Coarctation, it's a probability. We cannot speak about diagnosis of coarctation. We can speak about the probability. Third, very narrow right outlet, tetralogy of Fallot. Single vessel, normal size, TGA, corrected TGA, single ventricle or dextrocardia. Single vessels, very wide, truncus, tetralogy of Fallot or Dorf. And we should remember that if we are looking only on the structure of the incomplete figure 8, we can detect more diagnosis than the 4 chambers view. 77% of the cardiac anomalies appear in this structure. Other incomplete figure 8 abnormalities. Usually, in the beginning of the pregnancy, we have 2 aortic arches, and usually the right arch disappears. So we have here superior vena cava, trachea, and ductus arteriosus. This is the normal fetus. But what happens if the left arch disappears? No, okay. No. Okay, so this is the incomplete figure 8, superior vena cava, trachea, main pulmonary ductus is the same. Tube. We cannot differentiate the pregnancy between the connection. If we'll see the right and left pulmonary artery, this is the differentiation between the ductus and MPA, so I call it right outlet. So about double aortic, if both arches remains, we can see it it's about 20 years ago. And we can see that here is one arch, the second arch, and if we're doing transfer section, we can see the vascular ring around the trachea. Very easily, very quickly in the vaginal approach. Double aortic arch. And what is our experience with double aortic arch? With 11 cases, the incidence is about 1 to 5,000. Vascular ring appears in 100% of them. Symptoms, tracheomalacia, 9 out of 11 were symptomatic through the first year of life. D-George, out of this 11, it's not enough. None of them was D-George, but we believe that if it will arrive to higher numbers, one of them will be D-George. What happens if the left arch disappears? What we see is the right aortic arch around the trachea, and behind it, this is the ductus, and it creates vascular ring around the trachea. And it's 1 to 600, and we can see this is trachea, and we can see the vascular ring. And the autopsy of the vascular ring behind the trachea, week 16, here where it was the George, that's the reason she terminated the pregnancy. So our experience was right aortic arch with 78 cases, the incidence 1 to 600. In 95% of them, there was a vascular ring. Symptoms were only in 5% of them, the others were completely asymptomatic. The George was in about 5% of them. One case is an isolated finding, Down syndrome. ARSA, it's aberrant right subclavian artery, which can easily be detected in the early stage. It's sometimes be missed in the early stages. Here is the trachea and aberrant right subclavian artery, which is usually a benign variant, usually, not always. It's in the literature, it's written that it's associated very strongly with Down syndrome. So we did this research. And out of 20 cases of ARSA, none of them was trisomy 21. In 2 of them, it was abnormal CGH. In the same period with 17 cases of trisomy 21, none of them was ARSA. So ARSA is usually a benign variant, but we recommend to do CGH in such cases for these 2 cases. And now we have news. The ductus has also 2 arches. If one asks why in the right aortic arch only 95% of them are vascular, and this is the answer. Because in the early embryology there are right ductus arteriosus and left ductus arteriosus. Here is the trachea, superior vena cava, left ductus, right ductus. And according to the literature, before we published our article, in all of the cases when there was right ductal arch, it was associated with anomalies. This entity doesn't appear in the embryological textbook. This is the left ductus and the right aortic arch trachea. But what happened if the left disappears and there is the right arch? So here is the trachea, no vascular ring. So we have to see parallel vessels. And here you can see the parallel vessel. Here is the trachea, week 15. So no vascular ring. And look, this is the right aortic arch with left ductus, trachea. And here is the right aortic arch with right aortic arch. The trachea is outside. We had one case in which it's associated with anomaly. 1 out of 10 cases, maybe it was coincidence. So if we are looking about the views which Yagel and you published, we cannot detect this anomaly only through views. We should see the structure. And this is the structure which I see here. This is the right ductus, and this is the right pulmonary artery, and here is the left pulmonary artery, and superior vena cava. So the still vessels view, not practical in many cases, not just in it. And the ductus, some articles, is the black sheep in the family of great arteries. Brenishka wrote this paper because he was not informed about the possibility of right ductus arteriosus, because right ductus arteriosus may be associated with left aortic arch. So in such cases we can see the L shape of the ductus. Melpulman, the L shape, this is trachea, superior vena cava. And you can see here the L shape of the ductus. Again, main pulmonary artery, the L shape of the ductus, and here is the left arch. Left arch, right arch. And I believe that 5% of the ductal arches are right ductus. And here, to see it, this is the transverse aorta. If we are going above with ultrasound, not views, but looking at the structure, this is the right pulmonary artery, and if the ductus is parallel to the right pulmonary artery, this is the right ductus. And here is the left ductus, which is straightened, and the right ductus, which is L-shaped. So in my experience, I have only one case in which it was a right ductus, and it was the only anomaly in this Down syndrome. But I think it's coincidence. Take-home message. The ductus has also 2 arches. In 5% of right aortic arch, in 5% there is also right ductus, no vascular ring. Our hypothesis that it's also in left aortic arch there is also right ductus, which L-shaped ductus. Right ductus is usually not associated with cardiac anomalies, in contrast to the main line. In every abnormal ductal shape, the right ductus should be the differential diagnosis. Theoretically, there is a possibility of bilateral or right male pulmonary arteries. Other abnormal incomplete figure 8, we can see interruption of aortic arch. This is the aortic arch, no communication, no V or Y sign, and the aortic arch bifurcates around the trachea, and it appears that incomplete figure 8 is the X formation. They are not connected here. Another case, week 16, we can see all between the pulmonary artery and the aorta. And this anomaly is called aortopulmonary window. We had 4 of such cases. What about pulmonic stenosis, in which it is normal incomplete figure 8, but we should use the color. And the color we can see regurgitation and narrowing. And one of the cases we continued, and we can see membrane, week 17, transvaginal. And week 19 it turned to be hypoplastic right heart syndrome. So here it's the pulmonary atresia and hypoplastic right syndrome, week 19. It began with pulmonary stenosis. So what our experience with early pulmonary stenosis, and take a message. In 30% it disappears, although it may be associated with regurgitation. In 30% they will deliver mild pulmonary stenosis. In 8% poor outcome. Pulmonary artery, which is hypoplastic, and hypoplastic right heart syndrome. In 8%, they are not appear in the early stage, they are late onset, and some of them can appear also only after the delivery. And in 24%, they are not isolated. There was termination of pregnancy. One case was cardiomyopathy with nuchal edema, and we suspected a Noonan. What about the early aortic stenosis? Only 2 cases, about 1 to 2,000. 20,000, very, very rare in the early stages. Both of them terminated the pregnancy, so we don't know the outcome like in the pulmonic stenosis. What are the transient intra-aortic anomalies? And we can see the aorta, here is a flap inside the aorta. You see here the flap? This is the right outlet and the flap inside the aorta, week 15. And we call it persistent fifth aortic arch. And this is a MRI after the delivery. I think the earliest one which was diagnosed. So it might be transient, disappear later. She delivered no normal baby. And we can see 1 week later, we can see it's not an artifact. So 77% of the cardiac anomalies we can detect just looking at the structure from many directions. Okay, and out of about 300, and now it's all numbers, about 400 heart anomalies, only 4 appeared later. I'm not speaking about mild pulmonic stenosis. Thank you very much.